When today is obstetric hemorrhages, but majority of the questions that will be asked will be major obstetric hemorrhage and anesthesia. Okay, so it is a preventable cause of maternal death. That is a very important thing. Worldwide, hemorrhage remains a major cause of maternal death, and it is between one quarter and half of preventable maternal death are secondary to hemorrhage. So what is the reason for this is the physiological changes of normal pregnancy mask the clinical presentation. That is the most important reason why we fail to pick up the severity or the seriousness of the bleeding. And majority of the times we make a visual estimation of blood loss, which is notoriously inaccurate or hypovolemia. So just one or two pads, we don't know how much of concealed bleeding or the bleeding that has gone into the drain. So visual estimate of blood loss is very, very inaccurate. And any clinical evidence of maternal cardiovascular compromise may represent significant blood loss irrespective of the estimates. So if the mother's heart rate and BP are all out of range of normal values, then you have to suspect significant blood loss. And there is no universal consensus of a definition of massive obstetric hemorrhage. So what is the various definition that is given? What is the volume or what is the volume beyond which you say it is a massive obstetric hemorrhage? Mubin?
Sir, in case of vaginal delivery, more than 500 ml. In a case of cesarean section, more than 1000 ml. Or
that is all normal bleeding which
10%
can be tolerated.
10% of change in hematocrit from baseline. More than one circulating volume.
You are confusing between the massive transfusion and massive hemorrhage. So a blood loss of more than 1500 ml, any type of delivery, whether it is operative or non-operative, a fall in hemoglobin of more than 4 grams per deciliter after acute blood loss in a parturient. So you start with a hemoglobin of say 10 grams or 11 grams and it comes to 6 grams from 10, 4 grams loss. Then it is called a massive obstetric hemorrhage. Or there is a need for 4 or more units of blood within a short span of time. That is also called as a massive obstetric hemorrhage. So 3 definitions are there, 1500 ml or more, or a drop in hemoglobin of 4 grams or more, and the you need for more than 4 units of blood transfusion. So the poor outcome following this major obstetric hemorrhage have been attributed to majority of the times delayed treatment, unavailability of blood and blood products, inaccurate estimation of blood loss, absence of treatment protocols, poor communication among the treating teams, and inadequate organizational support. Okay, these are all the 6 reasons: delayed treatment, unavailability of blood and blood products. You just think it is a normal cesarean and don't reserve blood or anything, and suddenly after delivery of the baby, the uterus fails to contract and it goes on bleeding. At the time only you check whether there is a blood available in the nearby hospital, or you do it in especially in a small nursing home with no blood bank, then you are in big trouble. Okay, so that is the second important reason for the poor outcome. And the absence of protocols and poor communication. As soon as you find the mother is bleeding heavily, you must immediately communicate everyone and try to get as much as help as possible. So teamwork is very, very important, and inadequate organizational support. The main causes of massive obstetric hemorrhage. What are all the causes? Any idea? So it can be classified into 3 types depending on the time of pregnancy. The bleeding occurs antepartum or during delivery and the postpartum. So these are all the 3 stages of bleeding. So any bleeding from the genital tract after 24 weeks, some consider after 20 weeks of gestation, till the onset of labor is defined as antepartum hemorrhage. So the important causes for antepartum hemorrhage can be placenta previa, placental obstruction, coagulopathies, or uterine rupture in a previously operated patient. So during delivery, it can be lacerations during vaginal delivery, and postpartum it can be uterine atony or placenta accreta, increta, percreta, or retained placenta, and cervical lesions, dysplasia, cervicitis, all these things. And vaginal bleeding in placenta previa is classically painless, so that you must always ask whether the bleeding is associated with any pain or not, and usually seen in second or third trimester of pregnancy. Now coming to postpartum hemorrhage, which is one of the common questions that you will get in the exam. Causes of postpartum hemorrhage, as you rightly said, is usually 4 T's, which are tone, trauma, tissue, and thrombin. Okay. And the risk factors for developing postpartum hemorrhage are: one is uterine atony because of over distension, polyhydramnios, multiple gestation, and macrosomia, baby being very long. So preventive strategies: avoid prolonged labor. So take an early decision to go in for intervention and deliver the fetus by operative delivery, unnecessarily prolonging the labor, which nowadays all the physicians are well versed. They don't, even in a primary, they don't want to wait for more than 4 to 6 hours. Immediately they want to take up a cesarean. So that is why you are not seeing this as a main etiology for PPH. And prolonged stage of labor, use of tocolytics, and abnormal placentation, placental abruption, history of previous PPH, obese parturient, previous cesarean, instrumentation, assisted delivery, retained products, puerperal sepsis. All these 11 things are considered as risk factors. And preventive strategies: atraumatic assisted vaginal delivery, active management of third stage of labor, early diagnosis of placenta previa and abnormal placentations by using MRI if necessary, and planning for an elective cesarean rather than allowing for the normal delivery, and early clamping of umbilical cord, prophylactic judicious use of uterotonics, and planned multidisciplinary management of placenta previa and abnormal placentation. So if you make a diagnosis of placenta previa, that patient should be carefully watched, and you must plan as far as possible for an elective surgical removal of the baby rather than allowing for a normal delivery. So this is the protocol that should follow. Recognize early warning signs of MOH and establish basic non-invasive monitoring. Administer 100% oxygen by face mask. In case the patient is pregnant, nurse her in the head down and lateral position. Call for appropriate help. Establish 2 large bore IV lines. Send blood for cross match. Arrange 4 to 6 units of blood and fresh frozen plasma. Start rapid infusion of warm saline replaced by red cells as soon as you possible. So avoid giving too much of crystalloids. As early as possible, go for packed red blood cells. Combination of crystalloids and colloids can be given till blood is available. Send blood for basic investigations like CBC, renal function test, coagulation parameters. Use blood fluid warmers, warming blankets. Avoid hypothermia. This is one of the important mistake that mainly carried out. You are always concentrating on replacing the volume, but you forget to maintain the patient's body temperature. And ORH negative blood may be used if specific blood group is not available. Aim is to maintain normovolemia, monitor hematocrit, urine output, and hemodynamics. Prompt treatment of coagulopathy if it is happening, and early planning of surgical interventions if all the conservatives and pharmacological methods fail. And further management would depend on the cause of the massive obstetric hemorrhage. Now, parturient with massive obstetric hemorrhage may have features of hemorrhagic shock, and while being resuscitated can develop coagulopathy. So these are the 2 challenges you will face. Initially, it will be a hemorrhagic shock, which will be mainly concerning with the hemodynamic instability. Then they can, while you are resuscitating, if you give too much of crystalloids, or if you don't replace the coagulation factors adequately, they go for coagulopathy. So these are the twin challenges that will happen. So coagulopathy is caused by consumption of clotting factors and hemodilution. These are the two things which result in coagulopathy. So what monitoring you should do? Other than hemodynamic monitoring, urine output, hemoglobin, hematocrit, coagulation profile, that is platelet count, prothrombin time, activated partial thromboplastin time, plasma fibrinogen levels should be repeatedly measured. Very, very important. And point of care monitors now available and should be utilized. And the use of thromboelastography and rotational thromboelastometry for correction of coagulopathy is effective and quick in parturients. So targeted goal-directed therapy with specific coagulation factors based on such viscoelastic methods are associated with less incidence of allogenic blood transfusions and thromboembolic events. So that is the advantage of using this modern point of care testing. You unnecessarily don't give whatever is not needed. So thromboembolic events and blood transfusion reactions are all avoided. And use of blood products in the treatment, ideally cross-match specific blood should be given to the parturient with a massive hemorrhage. In case of non-availability of specific blood and a collapsing patient, O negative blood can be used. So this is only as an emergency treatment in a collapsing patient. It should not be used as a routine method. And infusion of large volume of crystalloids and colloids can cause dilutional coagulopathy, metabolic acidosis, tissue edema, and tissue hypoxia. This point I again and again stressed earlier. So just try to restrict this to the minimum possible and try to arrange for packed red blood cells as early as possible. Current advances in the management of hemorrhage in war-wounded army personnel have been extrapolated for treating the patients with massive obstetric hemorrhage. So it is a borrowed concept from treatment of trauma patients. The recommendations are to use packed cells and fresh frozen plasma in the ratio of 1:1 with early use of platelets also. And the massive blood transfusion protocol should be present in the delivery areas, keeping in view local expertise and facilities that are available. So every hospital will have its own protocol and the formulas will be mentioned. So you have to follow that. So all obstetric units should have immediate access to what is called massive transfusion pack, which is consisting of 4 units of O negative blood, 4 units of FFP, and 1 apheresis pack of platelets. So the composition of this massive transfusion pack is 4 units of O negative blood, 4 units of FFP, and 1 apheresis pack of platelets. Ideally, fibrinogen concentrate and prothrombin complex concentrate should also be available with this pack. This is the modern, because the components are now available, they have included this also in the pack so that it can ultimately be the end thing for resuscitation. And this is the what is called the level 1 infuser. You can see there are twin bags which can be held into that, and there is a switch here for pressurizing these bags, and there will be a heat exchanger which will be going through that, and you can see the warming recirculating solution is going on the sides and it will be able to warm the fluids whatever you are giving from 36 to 40 degrees centigrade. So the counter current recirculating solution at 42 degree provides a stable heating. So we can set it between 36 to 40 degrees centigrade. Otherwise, patient's core temperature will drop down to 32 and 30 like that if you use massive cold blood and other things. So heating is very, very important, and it has got some built-in safety features. Displays reservoir set point, monitors reservoir temperature, audible and visual alarms are there if the temperature goes to higher than normal what you set, and you can get the patient's volume status, whether you are, what is the speed at which you are giving, all these things are available in that. So the level 1 rapid infuser is a fast transfusion with a warmer, and it can be from 330 ml to 1100 ml with a maximal rate of 1400 ml per minute. That is the maximum that you can give. The temperature of the fluids can be between 36 to 40 degrees Celsius, and there is a gas vent filter designed to remove micro bubbles of gas in the line that can result in heating the fluids. So air embolism also is prevented. Now coming to use, the indications for the use is to provide rapid warm fluids such as crystalloid blood to patients suffering from hypovolemia and hypothermia. So you can improve the patient's temperature also. The contraindications are it should not be used for warming platelets or cryoprecipitates or granulocyte suspensions. They should be thawed and then only added to this. This machine should not be used for warming them. And during the course of use of that, you must monitor the vital signs, core temperature, IV line integrity, hemodynamic parameters, and urine output of the patient. And ultimate goal is to achieve a hematocrit of 27 to 30%. INR should be less than 1.7. Fibrinogen should be more than 100 milligram per deciliter, and platelet count should be at least 100,000 or 1 lakh per deciliter, and core temperature of the patient should be more than 35 degrees Celsius. So these are the 5 important things which you should achieve by doing this rapid transfusion. And coming to the thromboelastography machine, this is how it looks, and it tests the viscoelastic changes that occur during hemostatic process. TEG provides a real-time function of the coagulation cascade, platelet function, clot formation, clot strength, fibrin cross-linkage, and lysis. All these things are given that. So this is how the machine works. This is the cup, or what is called the cuvette. So this is a small cup that is there. It can hold 0.36 ml of whole blood, and there is a pin which is inserted into that. This is connected what is called the torsion wire. Okay. So the cup is rotating with a heating element, sensor, and a controller. Like from 4 to 45 degrees, it is keeping on rotating like this. And once the clot starts forming, this pin senses that, and there's a tension produced on this wire. And this tension passes the signals, which is now able to give a graph like this. So from the time you put the blood into the cuvette or the cup, from that time onwards, the first sign of clot formation is called the R time or reaction time. Then the initial clot strength that forms from here to this place is called the K time, and this is what the alpha angle is called. Then you get the maximum amplitude of the clot by this graph. So up to this, it is a coagulation phase. After that, what happens? The clot starts retracting initially, so it becomes smaller, and then after some time it starts getting lysed, so it becomes a fibrinolytic stage. So the maximum amplitude up to that is the coagulation, beyond that is the lysis stage. So based on that, R time is the period of latency from the time that the blood was placed in the TEG analyzer until initial fibrin formation. This represents the enzymatic portion of coagulation. Usually it takes about 4 to 8 minutes. So this is you can say the clotting time also. And R value of 11 to 14 minutes, the treatment is FFP 8 ml per kg. If the R value takes more than 14 minutes, then you have to increase the FFP dose to 15 ml per kg. Similarly, when there is a prolonged see, this is how the time will take. So the onset will take a longer time, whereas prolonged R means there is a failure of coagulation, whereas a shortened R means small time, it's a hypercoagulable state as it occurs in the early stages of DIC. And K time is a measure of speed to reach a certain level of clot strength. This represents clot kinetics, and the usual time is 1 to 4 minutes. Alpha angle measures the rapidity of fibrin build-up and cross-linking. This represents fibrinogen level. So the alpha angle decides the fibrinogen level, which is 45 to 75 degrees. So when the R is normal and K prolonged, then it is a platelet defect. So you can interpret that R is normal from the time of you place the blood in the cuvette to the onset of the clot formation is normal, but the initial clot strength formation is taking time, then it is a platelet defect. On the contrary, maximum amplitude is a direct function of the maximum dynamic properties of fibrin and platelet bonding via GP2B3A and represents the ultimate strength of the fibrin clot. So the maximum amplitude is usually 55 to 75 mm. That 80% of that is by the platelet action and 20% by fibrinogen. So platelet deficiency, this is how you will find there will be the graph will not be bigger like this. It will be smaller all through. And if it is a primary fibrinolysis, the size of that starts shrinking from here onwards earlier. So instead of the long one, you get a smaller thin line coming out. Then lysis 30 is the amplitude of reduction 30 minutes after maximum amplitude. This represents the lysis. Normally it is 7.5. So that is how that graph will look like. And in case patient has received heparin and then you want to do the testing. Nowadays what you have what is called heparinase added TEG is there. So instead of reversing it protamine, the heparinase patient prior to heparin reversal, you can test the clot formation or the coagulation status. And that test will also help to see whether you require more protamine or not. So this is called TEG with heparinase, an enzyme which will break down the heparin that you have given without allowing, need for reversing it with protamine and studying the coagulation properties. Similarly, you can remove the platelet effect by adding monoclonal antibody which binds the platelet. So by eliminating the platelet function, you can find out the fibrinogen activity directly, because I told you there 80% of the maximum amplitude is by the presence of platelets, 20% is by fibrinogen. So if you remove the platelet component, then you can find out whether the fibrinogen is normal or not. So these are all some of the common types of graph you will get. This is a normal graph with a, see the short R time, immediate K, then there is a maximum amplitude which goes on, and it should continue like a smaller tail. And if this long R time, that means the patient is on anticoagulants or the patient is having hemophilia. You can find the R time is very, very long. And if the patient is on thrombocytopenia or on platelet blockers, you find the whole graph is very thin, very small. And this both pointing front and pointing back indicates fibrinolysis. And if the amplitude is very high with a normal R time, that means it is a hypercoagulation. R time is also decreased to some extent, then it is a hypercoagulation. DIC actually has got two stages. Initially it is hypercoagulable, later on it is hypocoagulation with a prolonged R time and a prolonged thinner graph. Okay, so this is how the DICs will behave initially and later on. And so based on that, if you have a thromboelastograph and the activated clotting time which is more than 140, you transfuse FFP. And if the R time is more than 10, you give FFP. If the K time is more than 3, give cryoprecipitate. If the alpha angle is less than 53, you have to give cryoprecipitate and platelets. If maximum amplitude is less than 50, mainly platelets. And if the lysis time is 3%, then you go for tranexamic acid. So these are all the recommended transfusion strategies based on that TEG. Now, stages of hypovolemia, which we have already seen here, it is a class 1 to mild, moderate, and severe. In class 1, it's also called compensated. The blood loss is 15%, 15 to 30, 30 to 40, and 40% more, which we have already seen, and have been also mentioned that. So in this case, if we will clinically, heartbeat will be less than 100 in class 1. And class 2, it will be slightly more than 100, more than 120, more than 140. So if the heart rate goes to 140, that itself is an indication that the bleeding is quite severe. And in arterial BP pressure monitoring, normal because of vasoconstriction and redistribution, there may be slight increase in diastolic pressure. That is all the change that you will find. Whereas in the class 2, you will find the orthostatic changes. Into vasoconstriction becomes more and more to skin, muscle, and gut. So there is a redistribution. And in class 3, you will find there will be a drop in systolic pressure and decrease in perfusion of abdominal organs. And class 4, you will find both systolic and diastolic will be low, decreased perfusion. Respiration will be normal in class 1. There will be mild increase in respiratory rate, moderate tachypnea in class 3, and severe tachypnea in class 4. Similarly, mental status normal, anxious, confused and agitated, and drowsy or obtunded in class 4. Urine output is another indicator. More than 30 ml, it's class 1. 20 to 30, class 2. Less than 20, class 3. No urine output, class 4. Similarly, capillary refill time is another important measure. Less than 2 seconds normal, more than 2 seconds but clammy skin, so class 2. And class 3 and class 4, the time goes on increasing and skin also becomes pale, cold and clammy. All these things will happen. And coming to the types of placental abnormalities, you find this is a case of, this is a complete placenta previa. You can find the entire placenta is there with the bleeding, the baby is behind. This is partial. There is a partial encroachment into the cervical outlet and there is bleeding here also. This is called low marginal. There is no obstruction to the cervical canal. So this is marginal, but all these things can result in severe bleeding. And the other methods of placental abnormality are placenta. This is a normal placenta. There is a placental attachment with an endometrium, myometrium, and serosa. Whereas on the, if the placenta is including into the endometrium, but not going to the myometrium, this is called accreta. Then if it goes into the myometrium, it is called increta, and goes out of the myometrium, it is called percreta. So these are all the various varieties which are sometimes you have to know. And similarly, the babies, this is the normal placenta with the umbilical cord and the baby with the cervix vertex presentation. Whereas if the umbilical vessels are exposed without a covering and it is getting attached to that, then it is called the filamentous cord insertion. Whereas if it is presenting in front of the fetal part, descending part, then it is called vasa previa. The vessel coming in front, just like placenta previa, vasculature coming in front, it's called vasa previa. In this sort of conditions, there may be some bleeding, but mainly you will find only the fetal distress. The amount of bleeding may not be that huge or severe as you get it in placenta previa, and it will be mainly the form of fetal bradycardia or fetal Doppler blood flow reduction. All these things will happen, and it is a life-threatening thing for the fetus rather than the mother. And this is the condition of rupture uterus. So it can happen either at the previous site or below. So this will be how the rupture will happen, and there will be a huge hematoma around the near the uterine wall. So mother will go in for a hemodynamic instability. but vaginal bleeding will be very much limited. And you can see the parts may come out, and you can feel the baby's parts through the abdomen in rupture uterus. So it can happen both anteriorly as well as posteriorly. Now coming to the pharmacological treatment of uterine atony, which we have discussed, oxytocin is the first drug of choice. You can give 0.5 to 1 unit as a bolus and an infusion of 20 to 160 units. Methergine, then this methyl prostaglandin, misoprostol, and prostaglandin E2. All these things are all available with various dosages. Then coming to the invasive treatment for stopping the maternal hemorrhage, you can do what is called a balloon tamponade, uterine compression sutures, angiographic arterial embolization, arterial direct ligation by surgery, and hysterectomy. So these are all the various steps-wise treatment that you can think of. So the tamponade is done by this. There is a balloon available which is inserted into that. It just compresses the endometrium and tries to stop the bleeding. And this is the manual, bimanual compression by putting the hand into the vagina and then pressing the uterus from the top. But these are all temporary measures. If the coagulation is good, it may stop. But unless the uterus starts contracting on its own well, the chances of bleeding stopping is very remote. And this is called the compression sutures, where you take a suture from the site of operative area to both the anterior and posterior wall and then try to tighten it. So this is how that is done. And this is called embolization, where you inject a methacrylate solution or some sponge or foam, and then you can block the entire uterine artery. This is very effective treatment for stopping the bleeding. And this is a direct ligation of the uterine artery. So you can just go to the lateral aspect along the broad ligament and try to identify the roughly. You take a suture and tighten it. That will may also. This is a direct surgical method of uterine artery ligation. And then coming to the use of cell salvage and transfusion in this is the basis of cell transfusion here. So what you do is you collect all the blood from the double human suction catheter. You can separate the amniotic fluid and then collect the blood, bring it to the reservoir, then it is washed, all the waste products removed, and then the washed RBCs are retransfused into the patient. And here some heparinized saline is added so that it doesn't clot. And this is the way the saline goes into the machine to wash the clot. And this is the actual machine, how it is being used, the cell salvage machine. So it can be useful in placenta previa, Jehovah's Witness patient parturient, or rare blood group parturients, where AB negative group, which is very rarely available. So those patients, you can reuse them, which is useful. But the disadvantages are amniotic fluid contamination, and it lacks coagulation factor. So you have to give FFP separately to prevent further bleeding in these patients. Now coming to DIC, which is again another complication. It can be an acquired syndrome characterized by systemic intravascular coagulation. And coagulation is always the initial event followed by hemorrhage. So initially microthrombi occur extensively all over all the organs. So systemic activation of coagulation from the endothelial activation, intravascular deposition of fibrin, thrombosis of small and mid-sized vessels leading to organ failure, and depletion of platelets and coagulation factors, which ultimately leads to bleeding. So initially it is thrombus, later on bleeding, which ultimately results in death. This is what is happening. In the obstetric cases, there can be it is due to the placental abruption or the dead fetus, intrauterine death, or molar pregnancy. These are all the conditions which can result in DAC. And the conditions associated with endothelial damage, like in preeclampsia and eclampsia, and the conditions of non-specific or indirect action like amniotic fluid embolism, gram-negative septicemia, and saline abortion. That is when you put intrauterine saline to abort MTP. That also can result in DIC sometimes. And the mechanism is the trigger factor causes three reactions: activation of coagulation cascade, vessel wall damage, and platelet activation. All the three happen in this, which ultimately results in fibrin platelet thrombosis, which results in end organ damage because perfusion is not there. This can lead to coagulation factor deficiency, low platelet count, and then fibrinolysis activation also happens. So you find fibrin degradation products level will go higher. So that will be generalized bleeding. So initial thrombus in various organs followed by profuse bleeding. This is the stage at which you will find all the puncture sites start bleeding. So that is why initially you don't get a bleeding in these patients. What seems to have clotted suddenly opens out and stands or stops oozing wherever you have punctured the skin. And the hemorrhagic manifestations can be ecchymosis, petechiae, bleeding gum, hematuria, GIT bleeding, venipuncture oozing, intracranial or intracerebral hemorrhage. All these sort of bleedings can happen. And thrombotic manifestations can be in the form of, so DIC can be acute and chronic. Sometimes in chronic cases, you will find all the thrombotic manifestations more dominant. Dermatological and focal ischemic changes will happen. Renal with cortical necrosis, GIT, acute ulceration and bleeding, vascular occlusion, all these things will happen. Now, what is the algorithm for evaluation of factor deficiencies in cases of DIC? You can use PT and APTT. Just these two tests will be able to help you. If both are normal, it is mainly, and the patient is bleeding, it is factor 13 deficiency, which is very, very rare. If you have a prolonged prothrombin time and a normal APTT, it is mainly factor 7 because factor 7 is involved in prothrombin time. And if the prothrombin time is normal but APTT is prolonged, then there may be a problem with factor 8, factor 9, factor 11 and 12. When both PT and APTT are prolonged, it is a deficiency of factor 2, factor 5 and factor 10. So we can replace accordingly. So these two simple tests will be able to help you to find out what exactly is the deficit. So ultimate treatment of DIC is to remove the underlying cause, replenish depleted factors. Fresh frozen plasma provides source of most of the factors. Cryoprecipitate is the main source for fibrinogen, platelet and blood support, and cautious use of heparin. This is a little controversial treatment, but initially to prevent the thrombus formation, you can give the smaller doses of heparin, not the regular anticoagulant doses, but initially once you make a diagnosis of DIC, especially in chronic DIC, use of heparin or low molecular weight heparin will initially help in preventing the microthrombi formation, and then it will help in controlling the condition. Now coming to massive transfusion, what is the definition of massive transfusion? This is one of the other things that you are going to do. So more than 10 red blood cell units transfusion, which approximates to total blood volume within 24 hours. So replacement of one blood volume within 24 hours is one definition. Or transfusion of 4 packed red blood cells in 1 hour. The anticipation of continued need for blood is also called massive transfusion. Or replacement of more than 50% of the blood volume within 3 hours period, and transfusion support of to loss of more than 150 ml per minute. If all these things, various definitions are there. Whereas in pediatric, it is within same thing within 24 hours. Transfusion support replacing more than 10% of total blood volume in 10 minutes. Replacement of more than 50% by within 3 hours. These are all the definitions for pediatric patients. And initial laboratory investigations before you start massive blood transfusion, you have to group and screen the patient. CBC should be available. There is a pack available with the various tubes with two pink top tubes and lavender top tubes, blue top tubes. That is the cover of that collecting um, container, indicating so that it can be used readily for various tests. So INR, APTT, fibrinogen, electrolytes, calcium, creatinine, lactate, and venous blood gas sample syringe. All these things are sent immediately to the lab as soon as possible. So any person or any hospital which has a MTP protocol should have this sort of set of collecting tubules or test tubes readily available for separating them into various categories. And the monitoring that the patient should have during MTP are regular BP, heart rate, saturation, respiratory temperature, urine output, intake and output, and laboratory, CBC, INR, fibrinogen every 1 hour you should test, ABG or arterial blood gas or venous blood gas every 25 to 30 minutes, creatinine, magnesium, lactate every 4th hourly. And three approaches to the transfusion. It can be a lab based, it can be ratio based, or it can be point of care testing driven. So usually it is either ratio based or lab based. So ratio based is 1:1 between FFP and RBC. Now coming to transfusion of plasma administered during MTP at the rate of 1:1. It must be ABO compatible. Fresh plasma you give should be ABO compatible. Thawing plasma takes about 20 minutes, and if the patient blood group is not available, AB plasma will be issued. That is the safe to give if you don't know the group. And for transfusion of platelets, platelet count, if it is less than 100,000, then CNS and spinal cord bleeding or traumatic brain injury can happen. So less than 50 or all others, irrespective of this thing, you must transfuse. If the patient's count is less than 50,000, irrespective of the clinical bleeding or not, you should give. And it should be available immediately. For patients with PPH, platelets will be offered in the first cooler. That is, first shipment itself, platelet will come. And transfusion of cryoprecipitate is mainly for replacement of or the substitution of fibrinogen. Dose is 10 units. This also must be ABO compatible, and thawing and pulling takes time. And for patients with PPH, this also will be offered in the first cooler. That is, cooler means first shipment or first packs. Now, what are the goals of your transfusion? RBC is to be maintained more than 8 grams per deciliter, and transfusion of plasma 1:1 to 1:2 with the idea of maintaining INR less than 1.5 or APTT less than 1.5 times of upper normal limit. And transfuse cryoprecipitate to maintain fibrinogen more than 1.5 grams per liter, and transfuse platelets to have more than 100,000. So these are the four things. Hemoglobin should be 8 grams, plasma ratio should be 1:2 or 1:1 to maintain INR. That is the second criteria. Fibrinogen should be more than 1.5 and platelet should be more than 100,000. So these are the four criteria we should keep in mind to achieve by giving this rapid transfusion protocol. The adverse effects or complications of MTP are hypothermia, citrate toxicity. So this can be corrected by giving calcium gluconate 10 ml after every 500 ml of blood, or 3 to 4 ml of calcium chloride. So if you are giving calcium chloride, lesser volume. If you are giving gluconate, larger volume. You can cause overload of volume and abdominal compartment syndrome, transfusion reactions, acute hemolytic transfusion reaction, transfusion related acute lung injury TRALI, or transfusion associated cardiac overload, major allergic reactions. All these things are possible by MTP. Now coming to activated factor 7A, which has been used in the management for complicated coagulopathy. But the prerequisite for using that is you must have a fibrin of more than 1 gram per liter as you measure by that, and platelet should be more than 22 lakhs. And evidence is limited and concerns remain regarding increased thrombosis and lack of effect in the face of major hemorrhage. But the main reason is the cost is very, very expensive, and but it is useful in Jehovah's Witness cases where the if you identify factor 7 deficiency, then it will be definitely useful. It comes as a lyophilized powder, Novo 7, 1 milligram, which is 50 KIU. Any idea what is KIU? It is kilo international units. Okay, it is not just IU international units, it's kilo international units. It comes with a solvent, so you mix it and then make it into a solution and transfuse it so slowly. So the method of mechanism of action is it increases the tissue factor occupancy. That is tissue factor and factor 7A, they only activate the tissue factor activates factor 7A, factor 7A activates factor 10. So this increases this reaction, and pharmacological doses binds to activated platelets also and activates factor 10 independent of tissue factor. So recombinant factor 7A does not require always tissue factor, whereas the natural endogenous factor 7 requires tissue factor. So this can overcome that deficiency and cause a activation of factor 10 directly. Now coming to the last part, cesarean hysterectomy anesthetic challenges are, it is classified, it can be elective or emergency. That is when you know that the patient is having a placenta previa and likely to bleed heavily during, if you allow normal vaginal delivery, you plan for an elective cesarean section. So cases of placenta accreta, percreta or full placenta previa diagnosed antenatally by ultrasound, you can plan for an elective cesarean section with all um, uh, cautioning the blood bank, getting enough of blood and blood products, starting with both IV peripheral lines and central line to rapid transfuser, level 1 transfuser. Everything can be nicely arranged and you can safely give anesthesia for a very elective, calm atmosphere with a good result coming. On the contrary, if it happens because of PPH with failed conservative and intervention methods, then you will end up in an emergency hysterectomy. This is where most of the time you will end up with all the problems because you don't have adequate blood. It is odd time in the day. You cannot arrange people. So all the problems happen, and majority of the litigations also happen because of this sort of PPH with failed conservative and interventional method. So the anesthetic techniques they have used are combined spinal epidural, continuous spinal and GA. But majority of the time you have to know the surgeon's ability and how quickly the surgery can be performed by them. So based on that only you should choose your technique. So if it is likely to take a long time, there is no point in giving a regional and struggling and then trying to convert it in the middle to GA. All those problems can happen. So in that situation, better to go for GA straight away so that you will have a good control over both hemodynamic and respiratory function. Now hybrid operation theatre where combined embolization followed by hysterectomy, that is usually done under GA so that any amount of time can be taken by the surgeons or operator and you can complete it. So these are all the things that I would like to share with you. Now if you have any questions, you can ask.
Students, any questions? You can unmute yourself and ask questions.
I think class is so clear and evident. I think nobody has got any questions at all. Is it?
Oh, the subject was so clear, sir. Definitely, I also this presentation has made everything so clear.
Okay.
If they have been attentive, definitely the concept should have been clearly understood. There not be any doubts. But in future also they can put forward the questions to me either in WhatsApp or email.
Yeah.
I will pass on the questions to Professor and we'll get back to you.
Pratik Shukla, no questions? Shukla, are you there?
Sir, good evening, sir. I'm here, sir.
All clear? No questions?
Yes, sir. Sir, actually, in our institute here, we are using methyl ergometry regularly.
Regularly.
So-
Okay, still. It's a
so
good
that,
news for
that
me.
I was that I was worried whether I should continue it or not. Here
But
we are using
did
that.
you observe patient complaining of headache and tachycardia, hypertension happening immediately? Because we were using it when I was a postgraduate, I used to give that. In fact, ergometrin ethergin it is called. We used to
Yes,
give one
method.
ampule IV and the physician will inject one ampule directly into the myometrium. And within no time, the uterus will contract very fast. But at least 50% of the patients in those days, they used to complain of immediate severe headache and BP will go up to 160, 100 like that, which was hardly 110, 80 will shoot up. That we have observed. That is the reason why I think nowadays it's a long time since I stopped practicing OG anesthesia. So majority of the people now use only syntocinon as uterotonic, and in case some people use carboprast, which is of course contraindicated in asthmatics and other people. Yep. Right, that's a good news that you are still using it.